Welcome Ms. Agnes Seboa, who is a Senior Technical Officer, Adolescent and School Health. Round of applause to her. And you have just about 30 minutes for this. It's a lot, she says. Yeah, you can stand there.
Is someone projecting it? Yeah, Harriet. Yes, as we wait for the presentation to be aired for us here, I take this opportunity to thank the team that has organized this symposium. I know that we have quite a lot that we have to accomplish, but as they are uploading the presentation, maybe just to, pardon me? To us, we think this is a collective responsibility for us. But again, we have to speak reality. Our girls are getting pregnant. Some of them are dying while giving birth. I can give an example with the recent UDHS, the Uganda Demographic Health Survey results, clearly showed that that national level indicators on teenage pregnancy, we are still stagnant. In 2016, we were at 25. 2022, we are at 24. For the statisticians who are here, when you go into numbers, you know what it means. So we have quite a lot to do to put our synergies together. But again, the government of Uganda is committed to collaboratively work with the different key stakeholders in the prevention and response around the teenage pregnancies. But again, we see that this commitment is reflected first in the policies and the existing frameworks, because they guide us on how we are going to provide these interventions. For some of us who have read the cost of inaction report, how is this burdening the health sector at large? We know that if the current number, for example, of teenage pregnancy could be reduced to 10%, from 10%, for me, I know that the potential savings would be around, 5% reduction of the overall health expenditure. So let's look at teenage pregnancy as an issue that even goes beyond what we see every day. Is the presentation ready? Yeah. So this is how we look at it. The burden in terms of health expenditure, and it also impacts on how we look at the resources. Is it? see it here. What could be the problem? Okay. Okay, as we wait for us to project, as we are talking about the burden of teenage pregnancy, we look at our population. Pardon? Okay, is it projected there? Okay. Our population comprised of adolescents. The adolescent population, yes, goes up to 34.5% of our young people, who make up the biggest now percentage of the population, those who are aged 10 to 24 years, and 11.3 million. When you cluster into them, those that are aged 10 to 24 are 71%, and those that now, when you compile together, the 10 to 16, we see the 11.3. Yes, teenage pregnancy is a significant health and social challenge. We don't approach it from the health perspective alone, but it also poses with high morbidity and mortality for both the mother and the child. Remember, this is a mother, this is a child giving birth to a child. You can imagine, will this child be able to take her child for immunization? That's where we see that completing the immunization schedule becomes difficult. That is why we continue seeing children who are malnourished. So maybe some of the drivers and determinants of teenage pregnancy, we do not leave out gender inequality as a big issue, but again, sexual violence. The biggest percentage of those pregnancies we see are a result of sexual violence. Yes, including the harmful cultural practices. These young people contribute a percentage to maternal mortality, that is 17.2. The technology here. Can I get support? Okay. and has remained stagnant for the last 3 years, including with these recent statistics that have come out. 18.4% of pregnant women attending the first visit were aged 16 years over the last 3 years. But when you look at the regions, we have Lango, Bukedi, and Bugisu reporting the highest numbers. Kampala is having the lowest, but I know that more data will be compiled when you go into numbers. I don't think whether you'll be able to look at the districts that are shaded, but this has been explained that the 22 districts we see here had a teenage pregnancy above the national average, which is 24%. And the highest rates was recorded now specifically in Kole, Arua, Oyam, and Zombo. But again, we continue to see that in districts like Karenga, Kabong, Kotido, Kampala, Bushenyi, Mitoma, and Shema, we are seeing the rates being low. I know there have been interventions. I know that there have been a number of partners who are supporting this, but this does not mean that we clap our hands. When you go into numbers, we are still bad off. Now, what does this go with? I already said that we don't look at teenage pregnancy as it is, but it has, just like when you have a wedding, the bride and groom and the so-called peg boys and flower girls. What we are seeing here, we go on to look at the percentage of adolescents who received nutrition assessment. Yes, we see that from what we see here is that the screening has not been adequate. When you look at the financial year 2020 to 2021, this was low, 37.8%. The financial year 2021 to 22, we increased to 42.4% to 45.5% in our financial year 2022 to 2023. What we are seeing down, we clustered in the regions that while there are observed improvements, the overall less than half of adolescents get nutrition assessments. If we have health workers in the room, I think this is the time for us. Let's not only prioritize the under 5s, but also adolescents. We need to screen for their nutrition status. There are increasing trends across most regions, having the highest performances in Bugishu and Kigezi, and we are observing the low performance now in South Central. South Central has districts like Masaka, the Greater Masaka, Kalungu, and among others. So we see that there is lowest performance in screening for nutrition at 13.5% and North Central. It means that both North and South Central, we are not doing well. We need to do something. What do the pregnancies come with? STIs. The data now is disaggregated to the 10 to 19 years. We now see that the overall contribution of STIs among adolescents increased by 1.6 to 16.0% in this financial year we are talking about. When you look at the financial year 2021, we saw that we had over 18.20% of these new STI infections. And when you look at the financial year 2022 to 2023, it again rose. So it means that there is a very big problem there. There are challenges of the early sexual debut. There are also challenges of negotiating for safe sex, also low access to some of the commodities like condoms. So that's why we are seeing an increase in those new STI infections. Yes. So what I wanted to pull out here, if we are well observant, still the biggest issue is in North Central You see where it started now in the STIs. The biggest issue is in North Central and South Central that registered the highest. But again, this doesn't leave out the other regions. Let's not clap our hands because we are not that fine. I am seeing Ankole. Bogishu is also not doing well, including Southwestern that has Toro. Now, in terms of HIV, the HIV positivity trends, males versus females among our adolescents who are 10 to 19, we see that females have consistently showed higher HIV positivity rates than the males. But again, we emphasize the need for gender-specific interventions. We see that our females are more vulnerable. The new HIV infections are among mostly the females. The female positivity rates here decreased from 1.3 in 2020 to 1.0 by 2022, at least something there. But this doesn't leave out the fact that they are amongst the females. When you talk about the males, the positivity rates still stagnated by 0.6 with a slight increase of 1, that is 0.7 in 2023. But this doesn't leave us here. It brings suggestions in the importance of monitoring the adaptive strategies that are evidence-based. I think we can see for the different years, 2020, 2021, up to 2023, we see that the females are at a risk and vulnerable compared to the males. Okay. Like still we said, the number of post-abortion women aged 10 to 19 years, yes, those who received family planning. Remember the unsafe abortions, which our young people contribute to. As a facility or as a sector, for us, we are supposed to provide PAC, what we call the post-abortion care services. We see that 6,847 post-abortion women received FP by the end of this financial year. But we see that South Central reported the highest numbers. If we invited teams from South Central, I think this is the time. Even when we go back into the data for the different years, we are not doing well in South Central, financial year 2020, 2021, 2023. But this also doesn't leave out Busoga. Busoga is not also doing well, followed by Bogishu, also not leaving out Bukedi, where we have, Southwestern, where we have Toro. Bukedi is not doing that bad, but still, this is still a big challenge. So whatever data you see, we have not yet achieved. Our indicators are still not good. We need to do a lot. So when we talk about teenage pregnancies and early marriage, these are the things that come with the pregnancies and the child marriage. We talked of our mothers dying, where our adolescents contribute a percentage. We've been hearing questions wherever we move. Why are they dying? We know they are dying. They are contributing 17.2% of these maternal deaths. But what is killing them? What is the leading cause? So when you see, I don't know if you're able to see properly, for those who are less than 19, what we see in red is hemorrhage, bleeding. What we see in pink, still I'm pulling out for our adolescents, hypertensive disorders of pregnancy. And what we see in gray, there are some indirect causes like malaria, anemia, including HIV and other infections. And what we see in yellow, the pregnancy-related sepsis, and A smaller percentage of 8.0%, there are abortion complications. I still say abortion complications. So when you look at the ages, when you compare those who are less than 19, the adolescents, between those who are 20 to 24, there is a slight, change where you see that in terms of hemorrhage, those who are 20 to 24, it goes to 34.8% compared now to those who are less than 19 years. But again, when you look at the abortion complications, the 20 to 24 also pose a higher risk compared to those who are less than 19 years. So as a message, hemorrhage is the leading cause. When you compile, hemorrhage is the leading cause when you look at all the age groups. But again, the maternal deaths due to abortion complication and sepsis were highest amongst our adolescent girls and young women. Yes, this doesn't stop at STIs, nutrition, but also their mental health challenges which pose. We know that there are increasing trends of adolescents who are diagnosed with mental health conditions across both genders, both males and females. But again, we see this surface so much in Kampala, West Nile reporting the highest, and also Karamoja recorded the lowest. So I think there is a lot to learn from there. When you see that, when you look at it in terms of gender, we see that in Kampala, the females are much affected, the males are much affected, the females are much affected compared to the males. And also when you look at West Nile, we see that females are vulnerable to this. So what does this mean? As we are coming up with our interventions, we talk of an integrated package. We don't want to see interventions. For example, you're a partner looking at only nutrition. You run in a district, it's nutrition. You run in a district, it's malaria. We are talking of an integrated package of services that we provide holistically. As you're treating an adolescent for an STI, you screen for mental health problems, you screen for nutrition. So that's what we call an integrated package of services for our adolescents. We have priorities, but with these priorities, they are not a one-man sector. This is in collaboration with the different key stakeholders. And for us, we know that the key health sector investment areas for adolescent health are prioritized in our frameworks. And the first one is about the data. Yes, we talk of provision of appealing data, stroke information on adolescent health issues. We talk of the data so as to widen and deepen the participation and engagement of different stakeholders. Data informs planning. Data informs our interventions, how they should be placed. We don't leave out, for those who are in school, the school-based and school-linked health facilities that provide a full package, the integrated package I talked about of adolescent health, but also participation is not left out. We also talk of establishing a pipeline for rapid scale-up on effective local context intervention innovations. I don't know if you've heard of the group antenatal, because the main reasons as to why we were seeing even our adolescents not coming for antenatal or not even completing the visit, one of them was stigma. Secondly, some of them did not know some of the services, and also it comes with limited parental support. So we thought that when we put them together as adolescents to access antenatal care, in these groups they open up, they share, and it is really, it becomes effective as you're providing a service, what we call a group antenatal. They receive the services in an integrated manner without necessarily mixing them with older persons, like my age. Yes, this has not left us here, but we also talk about mapping, school facility linkage. It means that we have to map the schools to the health facilities so that appropriate and timely referrals are achieved. But we should note that although our adolescents need accurate information and services, their reproductive, maternal, newborn child and adolescent health needs vary by age, they vary by gender, and also by context. So don't think that what will apply for the 20 to 24 may apply to those who are 10 to 19 or beyond. So what have we done as a sector? I thought that it was prudent for us, before taking you through what we have done as a sector, to look at the burden. What have we done as a sector in terms of coordination? We have the national level, we have the working group, the Adolescent Health Working Group, that brings together key line ministries, health, education, Ministry of Gender, Justice, including water, Ministry of Education as well, including the other key stakeholders at the development partners, civil society, among others. And what we have normally is that quarterly we conduct partner meetings. Those are the quarterly partner meetings. Yeah, partner meetings. And at regional level, we have the local maternity and neonatal systems. Yes, that these coordinate the adolescent health interventions. At district level, my colleague already mentioned the district committees on adolescent health, which coordinate or oversee the adolescent health interventions at that level. But again, we also have the National Multisectoral Task Force on the adolescent girl, which also looks at the Multisectoral Committee on School Health. We have also gone ahead to look at the capacity building interventions at all levels, right from national level and sub-national level, where we have built the capacity of our health workers, but also looking at the peer model. We've also engaged the peers. In terms of bridging the information gap, we already have a call center, which is 24 hours, and we receive reports every month. And when you look at some of these reports, the issues discussed here keep coming up. We've also gone ahead to collaboratively work with the different line ministries to develop communication materials, because we know that the studies that have been conducted clearly showed that the reason as to why we are having more infections, teenage pregnancies, our adolescents have limited or inadequate information. That is why they are falling prey to such vices. Yes, we are committed to providing these interventions, and this is reflected in our policy frameworks. We have the National Health Policy 3, which has given birth to the National Adolescent Health Strategy, which is being worked on. We have meetings that are looking at updating the policy and strategy. But again, when you go down into service delivery, we have the Adolescent Quality of Care Standards. We also look at scaling up the use of digital platforms to increase access to SRH services, and also using the situation differentiated delivery models, which I already talked about. Thank you very much.
Much for the presentation. We're supposed to have a Q&A after this, so I'll request you to probably take a seat as we will quickly run through this. Ladies and gentlemen, if there are any questions, comments to raise, now is the moment. Can we have the second microphone? There was another microphone somewhere. Good. So, yeah, there was a hand first up that side.
Yes, with respect to pregnancy data or teenage pregnancy data.
Kindly, your name and...
I'm Lawrence Ogwari, I'm a DCDU BIM.
Great.
Recently, there was a concern with regards to the DHI2 data, especially from the Karamoja perspective. What we realize is that in the first trimester, there is a likelihood that not so many, okay, there are those that will not attend the ANC. And yet we rely on the first trimester's data. And what we are asking is what happens to those who pay visits in the second, third, or fourth? Because then we are only looking at this as a baseline data. What about these other ones who are attend afterwards? Who would have actually missed the first one? Thank you.
Great. There is a second hand here. As we move towards this side. Yeah.
Thank you very much. My name is Charicha ABC. I am a retired teacher, and at the moment on the sector of religious leaders. Before I submit my question, there were a few additions that were left out that I feel as a teacher, they also need interventions.
Okay, in just a few seconds.
Yes, I just want to, as a teacher, I now summarize. One of the causes of this, a predisposing cause is that's what we call maladjustment and delinquency, which is very common and predisposes our youth to this issue. And then there are two which are intertwined. The lack of parental involvement and societal involvement. These are two things that are intertwined. And they are the issues causing a lot of teenage pregnancies. But there's now one thing which nobody wants to talk about. Compromise when it comes to implementation of laws. This is where the problem is. Then, like the CDO said, even the little money that is secured for use in districts do not find their way down to the districts. So if you read the story of when the tortoise was ill, when the lion was ill, when the tortoise went to the door, the footmarks had gone in, and they were not outside and not inside. They said, where did the animals go? So when this money is released, it is not with the district and not in the treasury. Where did it go? It is supposed to serve that purpose, but nobody wants to address that. So at times we say you find them in the mouths of the involved, and we don't mention them. And these are the problems. Then the other is peer pressure. And peer pressure is too much in schools, more especially. And this is where we have sources of teenage pregnancies. Yeah. Now, when they talked of addressing barriers to interventions, there are barriers, all right. Now, and this goes to education. Citing all this, do you think there's a possibility of us ending this vice so soon, if these things are not addressed? So, can we get an answer to that so that we can speed up the process of saving our girls? Thank you very much.
Thank you so much. You see, when you talked about teachers, you reminded me about sometime in my primary school. Sometimes you'd think the teacher is coming to the close of the lesson, especially in the afternoon. Then he opens a new chapter. Oh boy, those were dreaded times, especially when you wanted to play some football. Next. Harriet, can we move the mic kindly? Yes, let's have him.
Thank you. I'm a Ituka Isaac Joaquino, a teacher by profession. I taught for 20 years in the primary school.
A round of applause.
And now a member of parliament representing the people of Upper Mali County in the Parliament of Uganda. I have three issues. One, in the presentation we saw that we have the District Committee on Adolescent Health. But then, to me, this is still too far from the real teenage girls who really have to be visited. I don't know what strategies we have to extend this up to village level, because we have the village health teams, the VHTs. I don't know if there could be a framework where we can bring the VHTs on board. It will be of greater help to do the sensitization on teenage pregnancy, because they are very close to the ground. Secondly, in the presentation we saw that West Nile is one of the regions with the highest mental health challenges. And those of you who have an opportunity to travel in West Nile, you will realize that the drug abuse is a very big issue. And we have contradicting laws which sometimes also promote the use of the drugs. So that is a big challenge. I don't know what specific interventions we can have to address the issues of drug abuse in West Nile. Then lastly, the biggest challenge, the biggest driver for teenage pregnancy is school dropouts. Yes, the government came with the UPE to see that children are kept in school. But we still find that the facilities in these UPE schools are wanting, to the extent that it even encourages these girls to drop out when we talk about menstrual health and what have you, where the facilities are not provided. What strategies do we have as a Ministry of Gender, as partners, to see that we keep these girls in school? Thank you.
Thank you so much, Honorable Member of Parliament, and we rely on you to be our ally, our ambassador on the floor of Parliament when we are talking about ending child marriages and teenage pregnancy. Honorable, next time I want to see you on TV making the loudest noise on the floor of Parliament for us to stop this vice. Thank you for turning up today. Next. Good afternoon.
My name is The previous speaker spoke about the mental health of the teenage pregnant mothers around and how they're helping them mentally. But what is the ministry doing to help them before they actually become teenage pregnant mothers, before they actually become whatever they are in their state? Yeah.
Okay, what are we doing before we go into the troubles? Thank you. Yes.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. My name is Nabanjo Shamira. I'm a student at IUIU and a Guild Lady Vice President. So I kindly have about two concerns regarding the topic that has been discussed on. When we talk about teenage pregnancies, as a medic, I think one of the causes, as we are looking at how to prevent whatever is coming on board, we are forgetting that we are living in an era whereby our fellow girls are sexually active at a very young age. And this is the truth that we are supposed to live with right now because of the technology and everything. Girls are very much exposed at this young age. And as the Ministry of Health, they need to kind of put contraceptives and sex education exposed to these children at a very young age. We used to be in primary whereby sex education was something that is very strange, but we are living in an era whereby a child has to be educated about sex education as early as 10 years. The same way the ministry came out and we are giving the HPV virus to prevent the cervical cancer. It's the same way that these girls have to be taught on how to prevent pregnancies. Because when you look at the hospitals, most of the young teenage mothers who die, it's not because they are delivering. Most times it's because they are trying to abort. And this is a very biggest number. They are always around 14 years, meaning they got pregnant, they knew they were sexually active, but they didn't have the right ways to protect themselves. So instead of you waiting for these young mothers bleed to death as they are trying to abort, it's better we introduce contraceptives to them as early as possible. We are preventing in that way than curing. The other thing they talked about as one of the causes is to do with hemorrhage in teenage mothers. Hemorrhage, I would say to some point I blame our government as well. Because, okay, I'm a fourth-year medical student. I've been in hospitals whereby when you look at our government hospitals, the maternities, when you go to the ward, some of the drugs that are missing are the drugs responsible to help us stop bleeding in these mothers. You find a whole maternity ward not having oxytocin, not having misoprostol. How would you expect this mother to go to a pharmacy, buy a drug to prevent them from bleeding, and then at the same time, they are the mothers who are, since they are teenage mothers, they don't even have caretakers. They come to hospitals with no caretakers. You have to write to them medicine to go and buy them. But who is responsible? It is our ministry. Why don't you equip the hospitals with what is needed to protect the lives of these mothers? Because most of the solutions we are putting are political. The most practical things are on the ground. When the mother is already delivering, do you have what it takes to save them? Do you expect a doctor to run to the pharmacy, which is a mile, to get oxytocin, save the mother's life? This goes back to our leaders. Like, we need more practical solutions to save our sisters who are dying, as we are also engaging the entire society to try to put this to an end. Thank you very much.
Wow. I think those have been a very good set of questions there and concerns you raise. Very, very, from an informed point of view, by the way, giving you experience, and the Minister of Health, all that she's talked about points at you. I'm looking forward to you responding to these questions more objectively. Okay, let's have just one more, then we get to the next session.
Thank you very much. My concern goes to Ministry of Gender. My name is Richard Obia, District Community Development Officer for Terego District Local Government. Colleagues, you are aware that sometime not far from now, we have been implementing Spotlight initiative in this country. And from the results that were achieved, our country came out to be the best. And we all attributed this success to the presence of the parasocial workers, not the social welfare officers. And when we were launching the successor program for Spotlight initiative here, the Permanent Secretary, Ministry of Gender, assured us that the issue of the social welfare officers was going to present it to the cabinet because of the incredible work that they did. I wanted to find out how far this process has reached. That's number one, in regard to addressing issues of teenage pregnancy and child marriage in our societies. Okay. Then two, Frank, when our sister was making presentations here in regard to achievements and your testimony in regard to this girl of Luero, 13 years old, that with all the struggles that you praised the probation officer, and you alluded to intimidations here and there, and the father of this girl has to come to the ministry, what has this story communicated to us? How many of these kind of fathers are going to come to the ministry? Thank you very much.
Thank you. Madam Manet luckily is still here. She's going to respond to those questions that touch the Ministry of Gender. So I know she's been preparing her answers. You'll get an opportunity to respond. I think that's it. Let's get the responses now.
Thank you. Thank you very much for the questions. Some of these, I'm glad there were comments that we'll ably take on. But again, there was a question from Lawrence, DCDO, Abim, on our data in terms of what happens to those who miss the first one and come to the second one. When they come in their second trimester, still we capture them as those who have come in the second trimester. But that doesn't mean that when they come in the second trimester, they are not going to be provided services. For no. When you don't come in the first visit, it doesn't mean that you will not get a service. You will get a service equally like any other mother who has come for antenatal, and you will closely be monitored. So that does not mean that those who don't come for the first antenatal care visit are not going to be cared for. No. We are there to provide a service. Yes, I appreciate the comments from the second speaker on the gaps, our teacher. I've forgotten your name. Yes, among the issues that we've presented, of course, there are reasons as to why we are still registering big numbers of pregnancies. There are reasons why we are having more new HIV infections. And I already mentioned that the biggest issue was limited parental involvement. But also, I brought out something on the laws, which may not be favorable in terms of accessing some of the services. We appreciate the peer pressure, but maybe just to say, when you look at health, we are at the tail end of everything. It starts with information. If we've not given our adolescents accurate information, we shall continue seeing them in the health facility. That's why I say that when you address that issue of information gaps, for us who are at the tail end, we'll continue receiving them. So this is a collective responsibility. And I already talked about the studies that were conducted. And the biggest issue was that our learners or adolescents are getting pregnant because they have inadequate information. That is the biggest issue. Once we address it, we shall see limited numbers in the facility, those who are pregnant. Honorable, you talked of the coordination, the DICA, yes, which we are seeing at the district. These district committees on adolescent health, maybe I needed to elaborate, bring together the different departments at the district level. That is health, education, protection, water, among others. These do not stop at district. We have what we call SICA or SICA, which we call the Sub-County Committee on Adolescent Health. And these sub-county committees on adolescent health report to the district quarterly. And even when you look at the representation, it goes up to the health bit at in the sub-county, the health facility in charge, including other players. We don't stop in the sub-county because where do the issues come from? We also have the village committee on adolescent health. So we have the national level, the district level, the sub-county level, and the village level. But these DICAs, we appreciate the fact that we have districts, we have municipalities, we also have municipality committees on adolescent health, city committees on adolescent health. So they go up to the village level, and it's the district entirely responsible for monitoring all this, not the national level. So this is what we have. Drug use has been a very big issue of recent. I don't know if you've been on social media. The Ministry of Health, in collaboration with the Ministry of Education, came up with a school awareness campaign. But in one of the key issues that really came out was drug use among learners, those in school, but also adolescents who are out of school. So there are interventions around there, but there was an issue of the biggest driver to teenage pregnancy as dropout because of no facilities to keep the girls in school. I think Ministry of Education, I know Rosette will come in, Ministry of Education has had enormous interventions around here so as to see that our girls keep in school. I know that menstrual hygiene is one of the biggest issues. There was an issue from Mr. Mwanguzi, mental health. What is the ministry doing? Of course, one, we established right from higher institutions of learning, we are establishing mental health clinics with good service providers, but also along the school. In fact, we started with one school from Lubiri. This is a pilot where we are having mental health clinics. I know that in most of our schools we may not have health workers, but when we talk of the collaboration or linkage between the school and health facility, this is where we see our health workers supporting both our adolescents who are in and out of school. Of course, Nabanja, yes, early sexual debut has contributed to these teenage pregnancies, like I mentioned, technology inclusive, but also we are working hand in hand with the different key line ministries, Ministry of ICT, to see that regulations are done. For example, who knows what their children are watching right now? Who knows what our children are watching right now? We are here at Sheraton. So we talk of regulation, but also it doesn't mean that the government is not responding. We already have the National Sexuality Framework housed in the Ministry of Education, and when you look at that framework, it gives us information to be disseminated to the different age categories. We have also gone ahead to extend services at community because we know that not all our adolescents come to the health facility. I know that there are villages that are very far away from the health centers, but we have conducted integrated outreaches. These outreaches that are conducted per village and are integrated. We see that different services are provided, right from antenatal care, screening for GBV, screening for pregnancy, screening for STIs, among others. Still, the government is also working day and night. For those who have read news, we are upgrading our health facilities. For example, if it's a 2, it is upgraded to 3, and we know that the level of service for each of the different levels of service delivery, Health Center 3, Health Center 4, up to the General Hospital. But again, the issue of commodities, we know it keeps coming, but still we are working tirelessly to see that our facilities at least are equipped with commodities. I know that within our facilities there may be gaps in terms when we are requisitioning for drugs also. You will not wait for drugs to get finished and you requisition again. There is always a system which is used to requisite for the drugs or commodities. Otherwise, thank you very much. These were some of the comments that I'm able to respond to. And others still, there are ongoing discussions at the senior management level as regards these issues. Thank you very much for God and my country.
May I request Madam Annette to go to the firing line and respond to the questions that were sent towards your direction.
Thank you, Mr. Richard Obia. I'm very sure of one question. You may have to repeat the second one, but let me give the response to the first question. It is true, under the EU-UN Spotlight Initiative, the step of increasing the number of social workers was made and was implemented. We look forward to an EU Spotlight Phase 2. Madame Ruta is present with us, and we believe some of the components of the social workforce could be supported under Spotlight 2. But a caution, even before we reach Spotlight 2, is that it's not sustainable, and I believe those questions were raised even under EU Spotlight 1, But it is a pilot that we chose to undertake, I believe, whose impact we shall measure. But come Spotlight 2, irrespective of how many social workers we shall be able to support, the big question of sustainability is still looking at us in the eyes. Because even within the local governments, we do not have all the staff we ought to have. We have some staffing gaps, and we cannot promise to fill the gaps of social workers, probation officers, and parasocial workers when everything else is still looking at us. That is my question, my answer, and yes, I believe the question for each one of us. That when we have incoming projects and they propose some options, we need to be careful with how much we implement those options beyond the project cycle. Because what Mr. Obia asked is, what is the fate? I think what should be important, in my view, as a programmer, is that we need to assess the impact of that step of having additional social workers as number one. Then number two, to see the element to which they can be supported again in phase 2. But again, as a development practitioner, when you support me to learn what to do or to fill gaps where I've been having them, then I should be in a position to support myself thereafter. So if I'm not able to support myself thereafter, then it has implications that maybe the pilot was appropriate at that time, but the pilot may not be sustainable in the long run. And as we close our symposium today, I believe those are some of the issues that our commissioner will briefly talk about, because we cannot, we cannot support every component of a program subsequently. But when we've been implementing a program, we can pick components that we are able to spend on, because that's what sustainability is all about. That is the best I can deliver, Mr. Obia. Please give me the second question, then I will leave the podium. Thank you.
Yeah, thank you very much, Madam Annette, for that response. Before I give you the second concern, the social welfare officer's support was actually from UNICEF. And I am aware that there was a number of exchange of letters between UNICEF, local government, and ministry. So the essence was that because of the incredible work that these people did, whether there was possibility to get these people in our system such that they can be able to continue now as like part of the structure under community services. Then the response of our PS by then was that, yeah, it is true, but this needed to go to cabinet and probably to need some time. So I just wanted to hear how far maybe the process has gone. But otherwise, thank you for that response. Then the second concern was about the Luero case. And I was saying that what Frank explained here pointed towards vulnerability in terms of handling some of these cases, because he was talking about intimidation
all the efforts that are made at that level have been frustrated, and this parent actually said that justice was not given him. And he opted, the probation officer guided him to come to the ministry. So now I was asking myself, because I'm very aware, my colleagues, the DCDOs who are in this room, probably they are going through the same scenario in the way of handling this kind of cases. So I was asking, what pointer is this giving us as a ministry in terms of our structure at local governments in handling this kind of cases? Thank you.
Thank you, Richard. I think the update from Cabinet about the status of the social welfare workers, you are aware it's a slow process. We can always get feedback. But regarding this particular case, I think professionals, let's do our work. That is my starting point. When you are intimidated in your location where you operate, it should not become a policy issue. That's number 2. Number 3, the ministry may not have the answer or the fallback position. Yes, to provide an answer for you whenever you come, because you are more than 100 districts. If you are violated as you handle GBV or any other case and then you run to us, I think we shall be burning our fingers. We need to let the right structures do their work, reprimand where appropriate, so that we don't run from our places to look for greener pastures at the Ministry of Gender, because they are not there. I hope I've answered you. I thank you.
Very good. Let's give a round of applause to Madam Annette and Agnes. Agnes, thank you so much for those very good statistics, pointers you have shared with us here. It's been very enriching to us. Ladies and gentlemen, allow me to recognize the arrival of the Commissioner, Gender and Women Affairs at the Ministry of Gender, Labor and Social Development, Dr. Angela Nakafero. A round of applause to her. She just joined us during the Q&A. It's a pleasure to have you, Madam. And she's come because she has a session to play at the end. Let me consult. So I'll give Annette 5 minutes, and strictly 5 minutes, to take us through the session on generating key and concrete actions from the discussions, and thereafter we shall invite the Commissioner to close this session. Annette, Harriet? Okay. Howard, please come. Come and recite a quick poem as Madam Annette gets set. She's going to do a quick poem.
It's an artist? Oh, wonderful.
Okay.
So you can sit for some few minutes. How much time do you think you want? 5 minutes.
Good afternoon, ladies and gentlemen, and the teenagers in the house. I'm dedicating this poem to the teenagers who have undergone all the challenges or the situations or the circumstances that have been spoken about today, this morning. I hope you enjoy it. I have a heart full of joy, a mind open with my eyes less biased, ears clear to listen, and with more thoughts to think about the times to come. When I say thoughts to think about the times to come, I mean a colorful, bright future. I don't mean attaching myself to someone who will make me feel like he's the whole world to me when I'm actually nothing to him. He tells you words like, without you, my life has no meaning. If I lost you, then I would never breathe. Yet he's physically telling these things to some other 2, 3, or 4 girls. Ignorant girl consoles herself with excitement while behind her back he exclaims, I've got her. And because he assumes he thinks smarter, he will look out for the smallest mistake you make to become the reason for your breakup. Calls you words like you're such an insolent, pathetic bitch, and some others that are too strong for my tongue to speak. Pregnant, innocent girl distorts, for her life is no longer in order. Her mind is filled with regrets. Her eyes are filled with tears, only because she believed in yummy, sweet, twisted lies. And now she feels like strangling herself with ties. So I become the next victim. You tell me the same lines, you know. Fortunately, you don't know that I know them. What I'm trying to say is, I am too smart to be seduced by you. You know, I never drink, so I'm ever sober, and my frontal cortex is ever functioning, and my reasoning capacity is its content. So you forget that I reason better, and I know that you will hang out with your friends for a drink camp, and I become the laughing stock. Hell no. I also want to finish high school without any person calling me his ex, without regrets in my life, with a mind open and a heart less biased, with success opening its gates wide for me, ready to embrace, with a cute smile on my face, saying, I made it. And so I still stand my ground. I'm an empowered, effective teenager, so don't mess with me.
Thank you, Hawa. As always, you're always amazing with your poems, very full of key messages and to the point. I want to thank you so much. And now I hand over to Madam Annette to take us through. Yes.
Thank you, Frank. I'm handling the last technical session, which is about closing. And I would have our main rapporteur to share with us a summary sheet of the action points from the meeting, and then I will base on them to incite a discussion on how we move forward. So IT team, please share with me the fact sheet of the key outcomes of the meeting. How much time do we need, Shiba? 2 minutes. So we can use the 2 minutes to reflect on what we have been thinking about as we wait for the rapporteurs to give us the summary sheet of the key outcomes of the meeting. But as we wait for the outcomes of the meeting, I think we need to reflect, because with or without that summary, we know we have looked at the service provision milestones in the life of the girl child. We have talked about the need at family level for the girl to get what she wants. That's why we talked about parenting guidelines and the other components of early child development. We talked about the school going age and what this girl needs: a comprehensive education, a fallback position of a supportive society and family, and the services she needs in case she becomes pregnant. We listened to a number of technical people from different sectors, health and gender, and education, and then the justice, law, and order sector. I think we could broadly categorize the services into those 4 thematic areas, and we know what the girls require under each. The question of whether we are delivering it is a different matter, but at least technically we know what we ought to give them. We later on listened to Agnes Seboa, Minister of Health, and she has given us very good statistics. But I warned us before that we need to know the reason behind the statistics, because that's what we plan for. Statistics are a figure, and we program for issues that are represented by the figure. So do I have the summary sheet, or I base on that to wrap up the session? You have challenges with IT? Okay. My rapporteur seems to be having a lot of stuff, and some from the audience. Can we pick 5 from the audience? I can start with you if you have 1. You have 2.
Exactly.
You have 3. You have 4. Okay.
Yeah, thank you so much. I have one which I think as we are having these discussions, we need to think of short-term and as well as long-term strategies. And I think we got to this place where we are as a country because for the last 20 years we've been doing short-term responses. And I hope in future we can also be having more, long-term thinking. 2 things. The need for having a very strong community system has come in, and I'm raising this also knowing that as government there is a shift to work from sector to program-based approach. But when I hear the conversation today, and I hear the kind of thinking that is coming on what could happen at community level, we are still also having very sector-based conversation. And I'm wondering at what point will you, as a human capital development program, start to think of an integrated language and narrative? I raise this because we hear the Ministry of Health talking around village health teams and community health workers that can play a role. We hear issues around parasocial and paralegal structures, and all these are supposed to be community-based, and each of the ministry wants to have their own human resources at that level, but we know the issue around human resource and how difficult it has been for each of your sectors to secure even the financing you need for your staffing gap. Wouldn't it be a right time to start thinking with a future lens how you can have a more integrated structure at that level? Because looking at the patterns that have been happening, I am not so convinced as individual sectors, even in the next 15 years, you will be able to have your paralegals, parasocials, VHTs for each of your ministries. So it's high time we could think of an integrated structure at that level that can be used by all ministries. I think that way you have better negotiation powers with government, because the bigger the structure, the difficult it is to negotiate with government for financing. So that's just food for thought, but I think it would be good to have such conversations next time. And then secondly, we've heard of the return to school policy. We do not know whether the ministry has done an evaluation of this policy, and you have really evidence of the realities, what's possible, what's not possible, that these girls are facing. Because I think where we are right now, we need to learn the lessons from all those and be able to come up with a broader strategy of how we want to deal with this issue. We heard in the keynote from UNFPA, we are going to live with this for 300 years. Are we going to be doing things like we are doing now, or we need to think more systematically and also think more structurally? Thank you. There are many. I hope we can submit them to the rapporteur for compilation. Thanks.
Okay.
Thank you. She has given me the mic.
She has given you the mic?
Yeah.
Yes.
So
Okay.
maybe I can... Okay, thank you very much. My name is Eric Tumoesije, and I work with Makerere University. I was just wondering, as we discussed, and this is at the risk of something that has already been exhausted, but I think I need to share it from my personal perspective. Those of us that have worked with these adolescent teenage mothers, when we studied the common characteristics, I know that all of us are vulnerable. My daughter, your daughter, is likely to get pregnant. But when we do a study of the characteristics of these girls that have gotten pregnant, especially looking at the socio-economic settings where they come from, what are the notes? What is coming through? And I want to make two suggestions among the many. One is that we need to strengthen families. Colleagues, the families are really at risk. If you go home in your own community and look around, there is a young lady who has left school at the age of 10, 12, here in town. Now, before we go out of, the city and other closed towns, there's a girl of 13, of 12 that has gone out of school with UPE in the community where they are living. What are the characteristics of these families? What are the characteristics of the fathers in these families that are actually nurturing these young ladies? So we need to strengthen the families. I was told here that we have parenting guidelines that are coming up. I'm not sure whether the parenting guidelines are family guidelines, because parenting, yes, it's not 100% a definition of the family setup. This could be two things. We need to strengthen the family as a place where these girls are growing up. But what relates to that, and my second suggestion is, can we bring these fathers deliberately on board? Can we have a conversation? We have read stories where fathers have given their daughters for a sack of maize, for a sack of cassava. Yeah? They have traded a daughter for marriage to get a bag. We have been raised by fathers who have dug in people's gardens to get both food and school fees, and they managed to pay fees. So sometimes poverty defines the extent to which actions can go on these teenage pregnancies and teenage marriages. But poverty in itself may not be the determining factor. Can we engage the fathers? That this Eric really gets into the understanding that as you get this daughter, this is not a property, this is not food, this is not wealth, this is not a shirt, this is not a bike, this is not supper. But this is a human being that God has given to you to be a custodian and to raise to someone useful tomorrow. Thank you.
We have another hand over there.
And just to add on what he said, this is a human being who wants to achieve the full of their potential in life, just like you yourself. With ambitions, where's the hand?
There.
With ambitions like anybody else, actually like yourself, you the individual.
Thanks so much. My name is Akoli Mwajuma. I'm an advocate practicing with Action Aid International Uganda, Gulu Field Office, as a project legal officer, Northern and Karamoja region. I have a few concerns. One of the doctors who were the panelists talked of access to contraception. From my field practice, I realized that we have some sub-counties in different districts that do not have hospitals. And these children or the community at large have to move so far distant to access the hospitals. And then also still from practice, I realized that we do not have some supply of family planning commodities. For example, Cyanopress has been out of stock for some time. Is there a way that the ministry can ensure that we have adequate supply of some of these family planning commodities in a bid to have access to contraception? And then also moving forward, if resources allow, can we look at building hospitals in some of these sub-counties? Secondly, let's look at service delivery points. For example, in West Nile, water sources, we have there is shortage of water in West Nile, and refugees have to move long distance in order to access these water points. These are some of the places where they end up getting raped and defiled. And all in all, we end up having early child marriage and teenage pregnancies. And then the question of doctors requesting for monies for filling the medical forms is still unclear. Yes, one of the panelists made mention that the government has some little funds to support these medical doctors to access courts when they are going to give testimonies as expert witnesses. Is there a way that the government can expedite the process of ensuring that these little monies are given to these doctors so that they do not ask for money from the survivors who end up abandoning their case and the perpetrators go unpunished? This sends a feedback to the community. Can we come up with a circular preventing them from asking for these monies? Because really our survivors do not have the money. Thank you.
A circular preventing these service providers from asking for money. The Commissioner Gender and Women Affairs is here. That is within her powers. Okay, a last one. Madam Annette, we need to wind this up. Just one more this side and that will be it.
You know, come on here. Janguan.
Thank you very much. I'm called Ismak Kemonges. I come from Sebei. I'm an activist. I wanted to just raise something the previous speaker talked about. He had talked about the enrollment as young mothers come in for antenatal. And in the statistics show, some come at an early age, the first trimester, and you don't see them. They come once and they don't appear. What are they doing to cap, or what is there a strategy? Is there a follow-up mechanism that they are using to track that what has happened, what happened to them? Because that could be a mechanism to also have them understand what they are feeling or what they could be going through. Then the other thing is, as young people, of course, understanding in such a situation, young people shy away from speaking out, of course, over such very funny things. But we wanted that the nature of hospitals that we have, they don't have youth centers where young people could come and occupy their spaces, socialize, have time to share with their other peers. At the same time, they are getting services. So I was thinking, what are strategies that can be done to see that young people also are considered on different health centers? Thank you very much.
Madam Annette, back to you to wind up the session.
Back to me, Frank. Thank you very much, members, ladies and gentlemen. I'm closing. And as I close, I wish to point out the need, the urgency, the importance of looking at our families again. Whatever is going wrong sometimes in the family, sometimes out of the family, but building on the packages that our girls pick from their families. We are looking at the parenting guidelines, but they are not an end in themselves. We need to merge them with the family policy, with the revised Uganda gender policy, which will be passed soon. I have the faith and the hope. So that we look at this girl from a comprehensive perspective. There are some proposals, facts captured by the team of the rapporteurs. You will have to read those. Do you have any other page, or you had only that? It's only this? Okay, we shall build on it. But as I wrap up, we have a high-level GBV policy dialogue on the 14th of December. And the theme selected for that high-level policy dialogue is focusing on parenting the girl child in the modern era. Because the truth is, we seem to have either missed or done both missing and missing, because the girls are not what they ought to be. They are not realizing their full potential, and the implications for us as Uganda are not very good. So you will receive your letters for the high-level GBV policy dialogue, and I believe in this policy dialogue, let's focus on the girl child, but let's focus on the girl child by not revisiting what we have talked about over and over again in reports, in submissions. Let us focus on what works. How do we raise our daughters in the modern era so that we do not lose them? Because the truth is, we are losing them, or about to lose them, or moving towards losing them. So if you have any views that you think will be shared in that dialogue, you can share them with me. I'm the rapporteur, the Honorable Minister is the chairperson, so that we can close this, because it has given us something to talk about every other time. You meet with the CSO, it's teenage pregnancy, child marriage. You meet with the government agency, teenage pregnancy, child marriage. You go to the church, teenage pregnancy, child marriage. I think it is time that we brought our heads together and got solutions that finally matter. I thank you very much. Frank, have your podium again. I'm tired.
Thank you so much.
Thank you very much.
You've done a brilliant job. Let's give a round of applause to Madam Manetia for helping us do a very quick wrap-up of what we've been going through since morning. Ladies and gentlemen, at this juncture, allow me to take this honor and privilege to invite the Commissioner, Gender and Women Affairs, to officially close today's engagement. Let's give her a round of applause as she comes.
Thank you very much, Frank. Apologies, I have an hangover of the GROW sensitization meeting. Apologies, I didn't join you at the time when I was supposed to be here because of other commitment. As Minister of Gender, Labour, Social Development, we celebrate another milestone of the generating growth and productivity opportunities for women enterprises, which we are looking at as one of the projects to solve some of the issues that are being discussed in this room. Because when we are poor, Poverty makes us more vulnerable and at times denies us from enjoying our human rights. So we believe that once we are able to ensure that Ugandan women are advancing economically, some of these issues at least will reduce, the impact will reduce. The mood in the room doesn't seem to be that very exciting, and I believe mainly because of the issues that we are discussing. I know the theme is telling us translating laws and policies into appropriate support services for pregnant girls, child mothers, and their babies. Yes, we celebrate the laws and policies, which are very strong. It's high time that as ministries, departments, agencies, and all service duty bearers are able to translate the laws and policies into services for these young girls. I believe we've discussed, we've reflected on how far we've provided the services. In case we've not provided adequate services, I believe out of this room we are all challenged. We'll do our bits and pieces in terms of ensuring that these young girls, the child mothers, the pregnant girls, and their babies are able to access the support services they require. This is part of our mandate, ladies and gentlemen. I also would like to congratulate you upon commemorating the 16 days of activism against violence. The critical area of focus is for us to unite and take actions in terms of prevention and response. So in the same way, we need to really take whatever is required to respond in terms of preventing teenage pregnancy, child marriage, but all of us know this is a violation, ladies and gentlemen. By the time I came in, we were discussing issues to do with the probation and welfare, the parasocial workers. As part of the EU-UN Spotlight Initiative, there was an added workforce to ensure that there is support required. I know there's no cut-out position on this, but I'm glad on the other hand to note that we are embarking on the implementation of the EU-UN Spotlight Initiative 2, where we are prioritizing sexuality education, skills for young people, sexual reproductive health, keeping the adolescent girls in schools. We'll be able to bring our different efforts together to ensure that we really take deliberate interventions to attend to the needs and interests of the young girls and their babies. So, in terms of moving forward, a lot has been done, but in terms of moving forward, we need to really focus on social norm change. Because all of us in this room agree that if we can stop defilement and sexual harassment, sexual abuse, we'll be able to do away with teenage pregnancy and child marriage. So it's a challenge to all of us, especially to the men and boys in the room. Can we stop sexual violence against these girls? Because if we do, then we will not have cases of teenage pregnancy in Uganda. So it's an humble appeal to the men in this room. Please go back, mobilize the men and boys to stop sexual violence against these girls. I know there are so many women who will be interested to engage sexually, but not with the children. Then secondly, still is upon all of us to strengthen our families so that we are able to provide a conducive environment for the adolescent girls to grow, to learn, and thrive. So parents, we have a primary role to play in terms of ensuring that our homes and families are safe. As Minister of Gender, we scale our efforts in terms of engaging men and boys, because we feel that if we make them our allies to gender equality and women's empowerment, we'll be able to achieve much. So I would like to conclude by saying, ladies and gentlemen, that change starts with me and you. If we support the girls, if we strengthen our families, if we nurture the girls, we'll be able to deal with some of the issues that we are discussing today. And of course, part of the strategy is we need to work hard in terms of getting out of poverty. Because, you know, the economies globally are not doing well. And so when we demand for free services all the time, that has a lot of implications to national development. So we need to work hard and get out of poverty and be able to at least contribute towards the social services that we are demanding from government. We know very well that government of Uganda is a primary role is to provide services, but also equally we have a role to play. So ladies and gentlemen, I would like to thank you very much for the time you spent in this room and the ideas that you've generated. I know we'll be able to get a chance to reflect on this and inform our future interventions around service provision to the pregnant girls, child mothers, and their babies. To the girls in the room, quite often we get challenged that when we provide services, we don't, in most cases, get the positive results we want. Instead, we at times get the negative results. So I would like to appeal to the girls in the room, especially the pregnant girls, the child mothers. Please take advantage of the services, report cases of sexual abuse, and confide with the parents and other social workers to be able to deal with the challenges that we go through. So thank you very much for the support. Don't hesitate to join us when we invite you to support us in the implementation of our activities, and we continue to count on your support, ladies and gentlemen. The issues are huge. Everybody needs to support the prevention and response to sexual violence, as well as focusing on the needs of the pregnant girls, the child mothers, and their babies. I'm glad that the discussion has started on service provision, ladies and gentlemen. With those few remarks, we'd like to thank our development partners, ActionAid, but of course the UN agencies and development partners that we are working with us in the provision of services. Together we can achieve much, and together we can transform the negative social norms into positive social norms that will impact on national development. So thank you very much for listening to me, and allow me to declare the symposium closed. For God and my country.
Yes, thank you so much, Commissioner, for closing this. Ladies and gentlemen, it's been a very exciting almost 12 hours for us here since morning. We've learned a lot, we've shared a lot. Heartfelt appreciation to all of you for your contribution, participation. Allow me thank the partners that made this possible. UNFPA, thank you so much. UNICEF, thank you so much. Ministry of Gender, Labor and Social Development, thank you very, very, very much for leading the preparations. May I also thank Action Aid for all they have done. But I want to most especially thank the district local government participants who have turned up here, the chief administrative officers, CDOs, and all the other partners. But more so, I want to thank the child mothers who made it here and have shared their experiences with us. We'd like to thank you so much. It's been very exciting. I want to thank the Embassy of Netherlands for bankrolling these engagements. Without that support, we wouldn't be here. I'd like to thank the Embassy of Netherlands. Ladies and gentlemen, this brings us to the end of our engagement. Let us stand united in the pursuit of a Uganda where every child can grow, learn, and thrive without the burden of early marriage or teenage pregnancies. See you next time. For administrative announcement, ladies and gentlemen, those who